Good morning, guys. Tony here, drinking my cup of coffee on Saturday morning and looking at documentation guidelines and billing guidelines. All right, so I get this question constantly, lots of misinformation out there. I posted some screenshots a while back and nobody seemed to care, so I'm going to do a video. Let's take a look at Optum. So Optum manages United Healthcare in a lot of states, and people are always under the misconception. This goes out especially to the higher volume clinics, clinicians that are working in high volume clinics. You know, there's this false perception that Medicare is the only payer that requires one-on-one contact. Medicare is the only payer that um, doesn't allow you to double book and double up and dovetail patients for one-on-one procedure codes. But I'm going to show you in the guidelines what Optum puts out, and Anthem Blue Cross Blue Shield puts out the same, and so many other payers. If you're an employee working in a busy clinic, it is your responsibility to go out and find this information. So let's take a look at this real quick. And this is just an open Google search. So let me go back so you guys can see where it's come from. Reimbursement policies, Optum. I just Googled something about, what was it, timed codes, reimbursement. And so this 0049 policy, if we go into it, I'm going to actually open one that I've highlighted. So you can see here, annual approval date, April 2019. You've got some basic information across the top. They're taking their guidelines from the American Physical Therapy Association's defensible documentation for patient client management. So it's not like they're making this stuff up. They're taking it from our professional organization and CMS. As we scroll through, and so, you know, the CPT code defines, and then we've got our main procedure codes here as services designed to improve function, have direct one-on-one patient contact, one or more areas. And then we go through. I'm not going to spend too much time on this top area. I highly encourage you. I'll post the link for this and you can read it yourself. Skilled decision-making, the thought process, documentation has to be more than just list of the procedures. There has to be evidence of knowledge and skill, professional judgment. There's a guideline for record-keeping policy, super important. Print it, use it, have it available to you if you're a private practice owner. You know, it talks about recorded, that the documentation for like a daily visit needs to be recorded each day. Substantiation of skilled services, that's nothing new. This one's important. Substantiation that the services met the one-on-one time-based requirement. So, you know, I hate to say it, but I feel like as clinicians, we tend to feel comfortable under a veil of ignorance because we're like, well, this is what we're told. You know, if we don't know, then we're not liable. You are. We all are. We're all held to a professional standard. So skilled intervention, obviously you need to know that, you know, with my topic of late, I've been talking more and more about what's not skilled intervention, what's open for self-pay cash-based services, how you can use a payer contract to open the door to allow you to build the self-pay side of your business, which is a huge value for the future. More about skilled care. This is the part that I think is important. This is where I want to spend the time today. So timed intervention, documentation should support the reporting procedure codes. The time reported to reflect direct one-on-one contact with the patient. Supervised treatment in the absence of skilled intervention is not billable, not a surprise. Billable time should reflect the time that the provider spent with the patient, not just the time the patient spent performing the supervised procedures. The amount of billable one-on-one units that can be charged per day is partly dependent on the number of hours per day that the licensed therapist worked. So you guys that are out there that are loading up a caseload with 3-4 patients an hour, producing all these units, no PTA, you have to understand that when your 40-hour work week is divided out, you have to be able to justify and substantiate that the total number of units billed is not more than the total number of one-on-one units available within a 40-hour work week. Don't forget, probably 15 minutes before your first patient, 15 minutes after your first patient, 30 minutes at lunch. That takes away an hour from each working day that you're not billing patients. I don't think the math adds up in a lot of these busier clinics. A licensed therapy provider cannot be one-on-one with more than one patient at a given time. Only the time spent by the therapist, provider in direct one-on-one care may be counted and billed as direct contact time. For me, so even if you take the scenario, and I think there's a lot of misinformation around this, even if you take the scenario where you say, okay, I'm in a state that allows me to delegate to a for us physical therapists, so a non-PTA, I can use an aide as long as I'm supervising. The aide can take the person through therapeutic exercise and I can bill for it. Well, the problem is the math doesn't add up. If I'm doing manual therapy on this this patient sitting in front of me, and I'm supervising an aide doing therapeutic exercise on a patient across the gym, even within my line of sight, I can't bill the same 15-unit block for these two patients. I can't bill an 8-minute and a 7-minute, right? Because the 7-minute won't count. So you have to not just look at your state practice act, but you have to understand the payer guidelines for the specific patient, the specific plan. The total time code treatment minutes must be documented in the daily medical record and consistent with the number of time codes billed, units and number of minutes listed below. And then it gets into information, which is useful. I'm not going to waste your time reading it because you can read, but talking about pre, intra, post delivery, face-to-face time with the patient, face-to-face time being, a key factor here. Here are the definitions for you guys. Get in here and check it out. Counting minutes. Again, I understand there's a discussion between like AMA guidelines, Medicare guidelines. They say clearly right in these numbers that, they're still counting the total number of minutes in the visit to act as a regulator for the total number of units that are available to be billed. So keep this in mind when you're looking. The other part that actually is new information to me that I never actually realized was they talk about 15 minutes as being the required, I highlighted it somewhere, being the required average. So many times we hear, well, you just need 7.5, just over 7.5 minutes, 7 minutes and 31 seconds. If you're consistently doing that, you're not averaging 15 minutes. You might have a couple 7.5 minute units, 8-minute units, but then you need a couple 22-minute units to balance it out. It's the average working out to 15 minutes. So it's in this somewhere. Sorry, I highlighted it and now I can't find it. But anyway, take a look at this document. I'm going to post it. If you're watching this on YouTube, please take a minute, subscribe to the channel. I'm trying really hard to grow the channel past 1,000 subscribers. I'll put this URL in the video description. If you're looking at this through Facebook, go to YouTube, find it, subscribe, look at the source document, and let me know what you guys think. You don't have to tell me what you're doing, what clinical policy is in your particular work setting, but I would love to hear what you guys think about this. If it's, obviously new information, if you already knew it. I look forward to hearing from you guys. I'll catch you on the next video. Thanks so much.